Richard.
Yeah, welcome everyone. My name is Richard Pyle. I'm a GP and also a lifestyle medicine physician and medical director for Thrive Tribe.
Hello everybody, I'm Chris Lemming. I'm the weight management clinical lead at Thrive Tribe. So I've been heavily involved in the kind of design and rollout of the program.
Thank you. And we've also got Tilly in the background here who is looking after the slides and the running of the session. So thank you to Tilly. Just to let you all know that the session is being recorded and mics have been muted. So do use the chat function throughout if you've got questions and thoughts along the way. We will make time for a Q&A session at the end. And we have also got one of our ops directors in the background as well, Jimmy. He's hiding away in the background there. So for those of you that don't know, as I say, just a big welcome to you all today. For those of you that don't know us particularly well, we are a healthy lifestyle service provider. We've been operating for around 17 years now, and we run various services throughout the country, including a number of NHS funded services. So we've got a lot of experience and knowledge in public health provision, and it's great to see so many of you on the call today. So I say thank you again. As an organisation, we're an ambitious organisation. We have an aim to help over 1 million people to thrive and build long-term behaviours. And as you can see, we are already well over, I think that number's a bit outdated now. We are well over a third of the way to meeting that target, which is wonderful. So just to give you a little bit of an overview on our experience as an NHS service provider. And the next slide, please, Tilly. Perfect. So we have a lot of experience in terms of Healthier You provision. We are a provider of the diabetes prevention programme and have been doing that since 2023 as part of the Healthier You brand. We currently work across 7 of the existing ICB areas, so Cornwall and the Isles of Scilly, Cambridgeshire and Peterborough, Derby and Derbyshire, North East and North West London, and South East and South West London. Due to our provision of NDPP, we are also contracted to deliver on 2 new NHS programmes, which includes the long-term conditions prevention pilot and also the behavioural support for obesity prescribing programme, which is what we want to speak to you a little bit more about today. We're about 12 months into that programme now, since it launched last summer. So we've got some great insights and experience of delivering that programme at this point. I know for some of you on the call today, this will be new to yourselves in terms of prescribing in primary care due to changes that have come into play this year. So hopefully this will give you a good insight into how the service runs, how you can refer into us, and also we want to share a little bit around patient experience of the programme so far, which is lovely. In a moment, I'm going to hand you over to Dr. Richard Pyle. He's going to take you through why wraparound care is important and why the service was brought into play. And then, as I say, we'll take you through what the programme is, how it differs from our different services, and also how you can work closely with us so that we can support your patients. But I'll be quiet for a little bit and I will let Richard share his knowledge and insight on the whys behind this.
Thank you, Emily. Welcome, everyone. Thank you for giving up some of your precious lunchtime to join us. Hopefully, we are confident it'll be well worth your while. I am just the warm-up act. The really important information will be shared by my colleagues at Thrive Tribe, the stuff you actually really need to know. But of course, it's worth remembering why we're doing all of this. And as a GP, as a cardiology gypsy, and as a lifestyle medicine physician as well, this is a subject which is very, very dear to my heart because the wraparound care for Mounjaro is absolutely crucial, and it's something that we're very proud of delivering at Thrive Tribe. Can I have the next slide, please? So this is a miracle drug, isn't it? Let's be honest. there have been sort of potentially miracle drugs that have come and gone over the years. They often turned out to be not quite as miraculous as it's thought they were going to be, particularly when it comes to weight loss. But it is undeniably the case that these drugs are very, very powerful and effective. We'll get into the potential downsides of them in a moment, but why bother when you finally have this miracle drug? That's certainly what all the pharmaceutical companies would like us to believe. Why bother having that support that goes with it when basically taking an injection, or of course, as of recently, taking a tablet twice a day is all that you apparently need? Hopefully we're going to answer those questions shortly. Can I have the next slide, please? I mean, the honest answer is that these drugs have limitations and that they're not, in fact, miraculous. They do help people lose weight, significant amounts of weight, and every time a new generation of drug comes out or a new version, the percentage body mass index that people lose, percentage of body mass, that they lose seems to go up. Side effects and tolerability may potentially improve, but they do have side effects, these drugs. They are not miracle drugs. They have very high discontinuation rates. In trial data, it's about 50% at 1 year. And we need to bear in mind that that is in studies with motivated people who've joined a trial, who really want the drug and want it to work. We need to then think about real world data, which of course is never as good as trial data because life is messy and complicated and people are not all well behaved and organised as they are when they're taking part in a clinical trial. We also have to bear in mind that these drugs don't have any long-term data for safety or efficacy. There is no way of getting around that. People worried about the long-term out things like vaccinations in COVID and whether those have long-term safety data, even though they save lives. Well, we definitely don't have long-term data for these drugs yet. So that's also worth considering because the more that we can do to help people early on in their journey, the better. And of course, what these drugs don't do is they don't address the root causes of obesity. I was once engaged in a debate in the Daily Mail health section, it was, with a professor about whether or not we call obesity a disease. I said it wasn't a disease. He said it was a disease. That's what the BMJ like you to do anyway. But however you classify it, there are multiple complicated causes for obesity. And unless a person has really worked on that, the stats, as we know, are not particularly optimistic in that weight regain when you stop the drugs is very common. It can be pretty rapid and substantial. And many people want, within a relatively short period of stopping these drugs, if they haven't done the work, if they haven't thought about their relationship with food, if they haven't made other changes to their life, they're going to be back where they were before they started. Next slide, please. The behaviour change is really important, and that's something that we are very proud of at Thrive Tribe. In reality, we all know the what. The reason that we're having the health problems we're having is not because there's an information crisis where we don't know that being overweight is bad for you and that eating highly processed food is bad for you. It's understanding the how you might want to start to make changes. So when it comes to behavioural support, weight regain after stopping the medications is significantly less. Long-term weight maintenance is significantly more likely. And resilience can potentially be improved as well. And I know resilience is sometimes considered a dirty word, but the reality is that building a support structure around you and a stronger internal support structure as well, and understanding who you are and how you work is always going to be better for you in the long term. Next slide, please. And psychological support is really important. Sometimes when I've talked to my patients as a GP, they come to talk about weight loss, but actually what's really at the heart of it all is pain and addiction. And if you read books by people like Gabor Mate, they talk about a lot. He talks about addiction pain being the source of addiction. That's the question you should ask. What's the source of your pain? And a disordered relationship with food and overeating can often be a result of pain. And sometimes I've said to people, actually, before we refer you to weight management, before you start taking the injections or the tablets, maybe we should be having a conversation about that. Maybe if you haven't had the chance to talk it through with someone and address it, then you should be. So that's worth considering, the additional support that they get through BSOP. And we also know that If you're in a group and you're establishing connections and relationships with other people, that significantly increases the chances of you being successful in the behaviours that you want to indulge in and the person that you want to become and the way that you want to think of yourself. People in your group can hold you accountable, they can be a referee, they can support you, they can be relationships that you build for the rest of your life. And whether those are face-to-face groups, virtual groups, that level of connection and accountability is really important too, because it can be a pretty lonely journey otherwise. And if all you're doing is getting an email from a pharmacist every couple of months sending you another prescription, then you're potentially missing out on something really valuable. Next slide, please. And we do know that it's important to think about the whole person. And the pillars of well-being you can see on this slide here, so I'm not going to read them all out to you. But the more likely you consider the person around, the more likely you are they're going to have a better outcome. And you can't try to address just one or two things whilst ignoring the others is rarely a recipe for success. Next slide, please. And there is evidence. This is scientifically based. Lifestyle medicine is evidence-based. And so are the benefits of wraparound care. So this was data from the Surmount and Surpass trials. They were both done with Tirzepatide, so completely relevant because they're about the drug that people are now getting on the NHS, whether it's from their GP or a locally commissioned provider. And in the Surmount trial, you were given wraparound care. And in the Surpass trial, you were given minimal lifestyle support. And as you will see, whether it was taking placebo, the 5 milligram dose, the 10 milligram dose, or the 15 milligram dose, your percentage weight loss was at least, if not more than, doubled in the people that receive support. So this is why it is required for a person who's getting their Tirzepatide through the NHS of that support, which is, of course, hugely beneficial for them. And the other reason that, of course, it's good to have this wraparound care, if we're being really factual and black and white about it, is because, and we'll go into this more as the presentation carries on, according to the cough indicators, this is a requirement for people who are receiving this treatment, and this is where ThriveTribe are here for you. Might be my last slide, but can we have the next one just in case? Yes. So that's me standing on my soapbox for a few minutes. I hope that's been entertaining, thought-provoking, probably not too much there that you didn't already know, but I'm going to now hand you over to my colleagues who are going to talk through the programme itself. Thank you.
Rookie error there, didn't come off mute. Thank you so much, Richard. Really, really appreciate it. I think it's always good and interesting to reflect on that research and why it's in place. So thank you ever so much. So yeah, we'll take you through now an overview of what BSOP and wraparound care looks like and why it was commissioned in the first place. Can I have the next slide, please, Tilly? Thank you. Oh, and the one after that. Thank you. So I'm sure many of you know by this point, this was all from off the back of newly issued guidance at the end of 2024, which highlighted that Tirzepatide could be prescribed through primary care settings. However, part of the recommendation was that behavioural support, wraparound care, accompanied that prescription, which is where we came in. Last year, NHS England needed to establish a pathway in a relatively short space of time, which is why the NDPP providers were asked to create an amended offering to support this particular audience group, and that's where we were approached. Currently, the service and the current framework is in place until the end of 2026. However, we know it's going to form part of the new framework for moving into 2027 as a standard offering. So we're not anticipating that there'll be any break in service delivery, and their service is going to go from strength to strength and grow into next year. As I said before, we're 12 months into the programme now, and so today we're hoping just to share a little snippet of some of the learnings and feedback that we've seen so far. Chris and myself are in a privileged position despite our roles. We're both practitioners and we both deliver on BSOP, which gives us a unique insight into experiencing firsthand working with patients who are on this pathway. So hopefully we can share some of that insight today with you. Can I have the next slide, please, Tilly? Thank you. So for those that don't know much about NDPP structure or BSOP itself, it's a 9-month programme, behaviour change programme, follows a similar structure and design to the NDPP for those that are familiar with it. However, it has been amended to suit obviously this particular audience, and it continues to be amended. The service is fluid in the sense that it's new and we're continuing to learn about it and amend and adapt to the needs of the patients. And Chris will be able to take you through a little bit more about what the programme content itself looks like. At the moment, we predominantly deliver the programme through digital platforms. So ourselves here at Thrive Tribe, we deliver the sessions in small group settings through Microsoft Teams. And we also work with our partners at Second Nature, who deliver the programme through digital app platform. Where there is demand, we can seek to provide face-to-face provision in the community. So if you in a particular area within your surgery or PCN area know that you've got a particular volume of patients for BSOP, it's not that we can't look to explore face-to-face delivery. But I'm sure many of you will know prescribing has been slower across the country, and the numbers haven't been there. And obviously getting patients into wraparound care and supported quickly is a big part of that. And so what we haven't wanted is patients to be waiting for months on end to join the programme, which is why the digital delivery has worked well. There is an expectation moving into Framework 4 next year that face-to-face will be just a standard part of that offering. And it's something we're familiar with and comfortable with, and we'll adapt to that as the need is there, really. Can I have the next slide, please, Tilly? It's really important to highlight here that behavioural support is very different and separate to the prescriber pathway. There is some variation in the pathways. However, the prescriber guidance is the same. So as the clinician and the prescriber, your role is very much around the medication prescription, so the prescription of the Tirzepatide itself, the monitoring of side effects, the comorbidities, ensuring that there's individual monitoring and regular clinical support throughout that journey. On our side, anything relating to behavioural support is where we come in. So for us, it's around the information on nutrition, physical activity, stress and sleep. We might give generalised information on the impact of Tirzepatide on health and managing side effects through diet and activity, but it's very general and sort of low level. The guidance is very clear on our remit, and anything beyond our remit, anything deemed to be clinical, would be signposted back to yourselves as the prescriber for appropriate management and support of that particular patient. Can I have the next slide, please, today? Thank you. You'll be updated as a prescriber, you'll be updated at various points throughout the patient's journey. So on receipt of the referral, you'll be notified if the referral is cancelled for whatever reason, once the patient is started the programme, and then obviously once they have completed, or if they disengage during the course of the 9 months. In addition to this, there are some new guidelines in place for the BSOP pathway. So we now have to ensure that patients are booked onto a programme pathway within 30 operational days of us receiving the referral. As I said before, wraparound care is very much a stipulation that runs as part and parcel of the prescription. So speed is of the essence to get patients signed up and engaged with the programme as soon as possible. As a prescriber, if we don't make any successful contact with your patient within 15 days, 15 operational days, so 3 weeks, you'll receive notification from us just to let you know that we've been attempting to contact the patient and we've yet to make successful contact. The patient will also receive communication to a similar effect that does highlight that if we can't engage them in the next 15 days, then they will be discharged back to the prescribing team. This is to keep you in the loop, and obviously as well, it may be that you see that patient in that period of time and can have that conversation with them if required, so you're in the loop. We do, outside of this, have varying communication levels. You know, if we are struggling to engage a patient, if a patient has shared challenges around their engagement, we do our utmost to ensure that's communicated to yourselves so that you're kept in the loop of the conversations that are taking place. Can I have the next slide, please, Tilly? I think this goes into Chris's bit. I can see a couple of questions that are kind of relevant to this point, which I'll just answer really quickly. If they stop behavioural support, do we stop the prescription for the tirzepatide? Our understanding from the guidance is that the two should go hand in hand. Obviously, your individual ICBs will have issued guidance. I am aware that a lot of that guidance is quite clear, that if the patient isn't engaging with BSOP, then they shouldn't be continuing with their prescription. I would always check your local guidelines, but generally speaking, I know for most of the areas that we work with, it's quite clear. So I will have conversations with prescribers through the weeks that are wanting to check their patients' engagement and to check that they can continue to prescribe. That's our understanding. In terms of the current waiting time to join a programme, there's very little in terms of waiting list at the moment. We've got excellent capacity. You know, you could refer someone today and dependent on their availability, you know, our next programme starts on Saturday. So we have good capacity at the moment. I think average time at the moment is around about 11 days from the point of referral to them starting a programme. But obviously that varies. Obviously there's a lot of factors that can influence that around patient availability, if they're going on holiday, which at this time of year can be quite common. So yeah, we're constantly reviewing and adding on new programmes, ensuring we've got adequate availability across daytimes, evenings, weekends, so that patients aren't having to wait too long. But again, if there's going to be an elongated period of time, that's something that can be to be discussed. Chris, I will hand over to you now to look at the programme content.
Thank you very much. Yes, so if you wouldn't mind, Tilly, bringing the next slide up, that would be wonderful. I appreciate the text on this slide, everyone, is very small. I'm not expecting you to read this, don't worry. It's just a bit of a side-by-side comparison, because as Emily alluded to earlier, to become a provider initially to deliver this programme, that opportunity was handed to the current provider of the National Diabetes Prevention Programme in each local area. And the programme itself, in terms of structure, mirrors the NDPP programme quite closely. So both of them are 9-month programmes. Both of them include 13 group sessions over that period of time. From our perspective, we see this as a behavioural change and a healthy lifestyle programme, with the outcomes kind of almost looking at themselves, taking that kind of... I've completely forgotten the word. That'll come back to me, ladies and gents. Apologies about that. But ultimately, we like to see this as a window of opportunity to support patients in addressing the underlying causes. So, of course, we'll touch on some expected elements such as nutrition, such as physical activity. But as Emily once again alluded to, there'll be quite a lot of in-depth support around maybe some of those topics that don't always get the limelight. So things such as sleep, things such as stress, just to name a couple. But ultimately, there are a lot of similarities for the current BSOP program compared to the DPP structure that people are quite familiar with. But of course, this is a different a different demographic of people that maybe need a little bit of additional support. So what we've done is made some quite key adjustments or additions to our current NDPP program to create a bespoke version of that for this program. So next slide, please, Tilly, and I'll just share with you all the key differences really between both programs. Now, firstly, you'll see on the left-hand side here, it says week 1, week 2, 4, 8, 12, and 16. So they are the times in which the groups will be taking place. But these are actually the first 6 sessions of the 13 in the program. So what we found is it'd be really helpful to maybe front load the specific information that directly ties to tirzepatide towards the front of the course. So ultimately, in the very first session, we'll share quite a bit of information around how tirzepatide can support that weight loss journey. As Richard alluded to earlier, as helpful as the medication can be, it isn't a miracle. For want of a better phrase, we do kind of still need to walk the walk. So we want to kind of explain a little bit around how all those different factors that can contribute towards success can intertwine, and how this program can support that process through that. And also, of course, the importance of those healthy lifestyle changes, not just whilst taking the medication, but we hope to develop those permanent lifestyle changes which lead to permanent health improvement down the line. Now, one of the key side effects, and kind of, it's not really a side effect, it's an intended consequence of tirzepatide, is a reduction in appetite. So something that has become really apparent and really important is how can we support people in providing their body with good nutrition and in enough food that's really nutrient dense, despite suffering from a reduced appetite. So that's a huge part of the program. We directly discussed that really early in session number 2. The reality is it comes up in pretty much every week that we deliver in some sort of discussion, because it's a really key part of the experience for our service users. Also, there are some other side effects that patients are maybe more or less likely to experience on the medications. And in the last year, we've had the privilege to deliver this now for quite some time, and it is really interesting actually to see the variance in the degree of which people are suffering from some side effects. Some service users are flying through the medications. They're at quite a high dose and not experiencing very much at all in terms of side effects. Some people do experience it a little bit more with lower doses. But also quite an interesting discussion as part of our program is helping the patients decide whether those side effects maybe are directly related to the medications, or actually are they related to the changing nature of their lifestyle, and are they experiencing things from that perspective, and how can we work through that with them. Of course, if you feel like there's anything that needs to be referred back clinically, as Emily mentioned earlier, we absolutely would do that, but we do try and support the service users to take a little bit of ownership of this and to start to understand their own body really, and build a little bit of connection back, often build a little bit of trust with the signals that their own bodies are and kind of sending them. And a huge part of that is maybe hopefully trying to support that process of building a really healthy relationship with food. So not solely looking at the physical side of nutrition in terms of nutrients and calories and all that good stuff, but also that more psychological element as well. Ultimately, if people can have a really positive relationship with food and maybe do spend less time eating emotionally, and it can be a hugely powerful change, not just for this kind of period of time, but permanently once again. Now, something that is a little bit different from a nutritional perspective, guidance-wise, is how important protein is when taking tirzepatide. Now, of course, we'd all love every pound, every kilogram of weight loss to be from body fat, but the reality is some of it will always come from lean tissue. The importance of protein is elevated here, particularly when people are feeling less hungry and maybe eating a lower amount in terms of overall calories. Trying to take a protein first approach and supporting patients with some real practical tools to take that approach is really important to preserve as much of that muscle mass as possible. to maintain a positive metabolic rate as well along the way. And resistance training comes into that equally as well. So we don't necessarily do exercise during the sessions themselves, but we have plenty of resources and plenty of discussions that support those patients in finding methods that work for them to engage in elements of resistance exercise as well. And then lastly, the bottom one on here is the importance of hydration as well. We would cover hydration anyway, but we're experiencing people maybe find it more difficult to stay as hydrated as they'd like. So just a real focus on, again, some practical tools to really visualize what's going on inside of their bodies for that. And also looking at meal planning as well. Again, that relationship with food and that routine that people have maybe got into over potentially decades is likely to adapt slightly here. So some support in how to directly plan for those changes hopefully makes it a slightly easier process to make some lasting changes for that. If you wouldn't mind going to the next slide, Tilly, this will be my last one. So ultimately, all of our topics, all of those 13 sessions will loosely cover something that you can see on the screen right now. And as much as we might be, of course, all really aware of these components, we often see them quite separately. But the reality is they all intertwine, they all interact with one another, and there can be a real domino effect. So if we can support the whole person, then the outcomes for weight loss hopefully are just part of the positive picture at the end of it. And the very last thing for me to share here is also what we're experiencing in delivering this program, which maybe does differ slightly from other programs that we've delivered, is that there is still a little bit of a stigma around these medications for some people. Maybe are feeling a little bit embarrassed or maybe feel a bit secretive about taking the medications. Certainly don't seem to be too keen to share that publicly with people. So what we often find is in these group environments, this is the only interaction that the service users have with other people that are experiencing something similar to them. So we found having some time in each session to really allow that peer support, to share their experiences and to work through those challenges and those experiences together it's always important. But we found it's kind of even more important on this program compared to some of our other ones. So yeah, the information is really important, but it's maybe the implementation of that information and that peer support along the way. And what we hope is we've put together a really strong package that supports the whole for all of our service users. So I'll stop talking now and I'll pass you back to Emily.
Oh, no, thank you so much, Chris. That was really helpful. And yeah, I mean, there's so much we could say, isn't there, about the programme. As you can probably tell, we're very passionate about what we do and what we deliver. So yeah, we could do a whole session just on that side of things if we had the time. So thank you. Brilliant. So I am going to take you through what the current eligibility looks like for BSOP, and then a little bit on how to refer to us. So next slide, please, Tilly. So as you'll all know, BSOP is only available to those who are being prescribed Tirzepatide in primary care. We often get a lot of questions from patients wanting to know if they can access BSOP when they are purchasing Tirzepatide privately, or if they're taking Tirzepatide for other comorbidities. But it is specifically for patients who are being prescribed Tirzepatide for weight management through primary care. It's only accessible for the patients across our 7 contracted areas that I spoke about at the beginning of the presentation. And at the time of referral, it's the prescriber's responsibility to decide if BSOP is the most appropriate referral route, or if another service is more suitable. So sometimes patients are in a position where actually at that point in time, they would benefit better from talking therapies or additional psychological support, for instance. So it's just making that decision at that point in time. There's normal exclusion criteria in place for the pathway. Patients who are pregnant, under 18, or have active eating disorders are automatically excluded from the programme. Next slide, please, Tilly. So I'm sure you'll all be aware we are now accepting referrals for cohort 2. So cohort 2 changes now mean that patients with a BMI of 35 or more, adjusted to 32.5 for some ethnic population groups, is now the criteria. It's still 4 out of the 5 comorbidities that must be present. So these include hypertension, type 2 diabetes, dyslipidemia, obstructive sleep apnea, and cardiovascular disease. As an organisation, we don't assess or question the eligibility of BSOP referrals unless there's something really obvious. So, for instance, if they meet the exclusion criteria and they've slipped through the net. But on referral, you are required to confirm that the patient meets the eligibility criteria, and we are expected to accept that information at the point of referral. Thanks ever so much. Can I go to the next slide, please, Tilly? Thank you. So how to refer to us. So at the moment, you most likely will have access to our referral form on your local IT system. So dependent on your local systems might affect how it has been set up in your area. However, most of you will have access to it through your clinical system to use the pre-populated referral form, which you can complete and then send to us at our NHS inbox, which is healthier.you@nhs.net. So quite simple. There's not a whole lot of information required on the form. Simple contact details for the patient, and as I say, confirmation of their eligibility to join the programme. However, can I go to the next slide, please, Tilly? NHS England are piloting using the ERS system in order to make referrals into the BSOP programme. Can I go to the next slide, please, Tilly? So, as I'm sure you're all aware, the e-referral system is the digital platform nationally that enables GPs and prescribers and varying clinicians to refer patients to specialist services. They're trialling this for BSOP to help try and streamline the referral process and to test the integrated pathway to improve efficiencies, as well as enhancing data quality as well. So this is very new in terms of the pilot that they are running. Can you go to the next page, please, Tilly? Benefits they see from coming from using the ERS system: obviously faster referral process, takes out paper forms and manual inputting of information, standardizes the template. So I know that sometimes templates are localized. Secure system, secure tested system, faster processing, and obviously they'll be tracking throughout apps as well. And it helps to, at the moment, they want to test this model so that to see if it's scalable moving forward. From our side, obviously, it speeds up the receipt of the referral as well, because there is no need to process the paper referrals. They come straight into our system for us to pick up and begin to make contact with that patient. Next page, please, Tilly. Lovely. So NHS England, obviously the hope is using this pilot that there's lots of benefits to that once eligible patients are identified and they're referred using the ERS system, that they are notified and contacted very swiftly. Notification updates will be received by the NHS app, and they should move perhaps a little bit more swiftly and quickly through the system and through the process. As I said, at the moment, this is a pilot, so NHS England are very keen for surgeries and areas to pick up the pilot and have a go at trialling this to see how it works. If you can go to the next slide, please, Tilly. If you are interested in the pilot and want to find out more, you can contact the team at NHS England directly. Their email is on the screen here. There is some additional information through their website as well. So we'll share this in the notes that we circulate after the session today so that you can take a look. But yeah, there's only ourselves and another provider at the moment that are trialing this pathway. And obviously the more people that test it and pilot it, the better we can understand the benefits for yourselves as the prescriber, but also the patient journey as well, with a view to hopefully this being rolled out as more of a standardised process moving into Framework 4 in 2027. So if you do have any questions, definitely do direct them to the team there. They're keen to speak to people and help you. They're there to support you and help you get set up using that pathway and using the RS system for BSOP if you're interested. So do give them a shout. But you can continue to use our normal referral form and emailing that in the interim. That's not been taken away at all. Thanks, Tilly. Can I go to the next slide, please? We'll move on because I touched on that earlier about how quickly we've got to contact patients. So if we can go to the next slide, please. Perfect. So there have been a few changes in 2026. So you'll be aware of the new QOF indicators that have been brought in from April this year. So there's 2 new QOF indicators, OB004 and OB005. OB005 relates specifically to the prescribing and management of Tirzepatide and the referral to BSOP. So this is where this particular service comes in, relates very specifically to that QOF indicator. Obviously, there's been a lot of change and there's lots of information out there. So definitely take some time to familiarise yourself with the new indicators and what that means for you and your teams, if you haven't already. But just wanted to flag that shift that we've seen this year. Thanks, Tilly. Can we go to the next slide, please? Lovely. So where are we now? As I said, we're 12 months in, which has absolutely flown by for all of us. So all 7 of our ICU bay areas are now live and referring into the system. We've received over 1,000 referrals now. And as I said, there's an average of 10 to 11 days at the moment to programme start. So from us receiving that referral to the patient getting started on the programme. As I said before, lots of things can influence that. But yeah, relatively speedy at the moment. We've had 670 patients that have already started a programme and 89 that are currently awaiting programme or pathway starts. So that's where they've picked their programme and they're signed up and they're just waiting for that to start in the coming weeks. Consistently seeing an uptake of at least 70% between the referrals received and the patients that are getting started. Over the last few months, we've seen that increase to 80%. So the appetite and the interest for patients to engage in BSOP is very strong at the moment. And we are seeing our first lot of patients finishing the programme. So I think we've had our first 3 groups that started in early September 2025 have now completed. So both myself and Chris have had groups that have completed in the last few weeks. Which is always a bittersweet moment to get them over the finish line, but you've got to know them so well in that time. So it's been a real privilege. What we are seeing is some fantastic outcomes that are coming out of the programme though. If we can go to the next slide, Tilly. And I wanted to share this because both Richard and Chris have alluded to the fact that we know that Tirzepatide, maybe isn't the miracle drug that we think it is. People are responding in different ways. Some people are seeing fantastic weight loss outcomes, where others aren't necessarily seeing the weight loss, but that doesn't mean that they're still not seeing positive clinical benefits from their journey on Mounjaro. And these 2 examples really highlight that, where We had one patient who didn't really lose any weight at all. However, their blood pressure, cholesterol, both were greatly reduced and back into normal clinical ranges. Their mobility was improved, energy was improved, overall well-being generally improved. I think this particular patient said to me, they just feel better in themselves. They feel better able to go about their day and having the energy to do what they need to do, which becomes self-perpetuating at that point, because then they're motivated to want to do more. This patient lost over 15% of their weight, which was absolutely incredible. Equally, HbA1c, blood pressure, breathing, all saw drastic improvements. Patient also shared they'd seen improvements with their mental health and well-being and feeling more in control with their comfort eating. Chris, I think this was somebody that you saw through one of your groups, wasn't it? And we just loved that initially they felt that the medication was responsible for everything. And actually that realization that this is actually me, this is who I am now, I'm just doing what I do, and I've got responsibility for that, was a huge shift in behavior and mindset for this patient, which is just always incredible to hear about. Can we go to the next page, please, Tilly? We recently carried out an advisory forum with our patients on BSOP, where all of our patients were invited to come and share their feedback with us, which was really insightful. And there was some absolutely wonderful feedback that came through those avenues. You know, the journey is a marathon, you know, that it's not an overnight success. Chris said it before, we still got to show up and put the work in. And actually, I think patients sort of relish when they realise that. I've never before felt so motivated and determined, and real enjoyment of the group sessions. The peer support that's gained through the group sessions is just as, if not more, valuable than the information that is imparted in those sessions a lot of the time. They really enjoy the community that they create in their groups, that it's a safe space, there's no judgment, no, you know, they all know they're in the same boat, they're all there for the same reason. They give each other accountability and support through that. And freedom and liberation, these were themes that came out in the conversations that we had with them, where just a complete change and shift in their mindset, which has been absolutely fantastic. So yeah, it's these patients that we see through BSOP come with their challenges. However, they are a highly motivated group for the most part, and getting to work with them and see them succeed is a real privilege for us. That has been a real whistle-stop tour into BSOP, and what we do, and what the programme entails. So hopefully that's been helpful. We'll open it up to Q&A. I've answered a couple in the box already, but we will work through the questions that have come through. So thank you for popping some in there. So let me have a little look. Sabia, we've done a few referrals and have been advised of a long waiting list. Patients are desperate to start Tirzepatide. So Tirzepatide has been commenced before they are seen on BSOP. Can you advise what the waiting times are? I'm not sure where that information's come from, Sabia. We don't have long waiting lists at the moment. As I said before, we've got excellent capacity. Our average start time for referral to programme start is only 11 days at the moment. Generally, if someone's waiting, that's normally due to availability in their diaries. So if they're going on holiday and things like that. You know, our biggest challenge at the moment is low referral numbers. So the more referrals we've got, the more programmes that we can put on at varying times, which will help to speed up getting patients into sessions. You know, we'd love to offer more and give more options, but given where we're at, we are still turning those around quite quickly. We have to report to NHS England monthly on waiting time. So we have to report on patients that are waiting over 30 days, over 60 days, and very rarely over 90 days. But those have been very exceptional circumstances and have been more down to patient circumstance than us not having a programme for them to join. So yeah, I'm not sure where that information's come from, but I hope that helps to reassure you that yeah, your patients don't need to be waiting a long time to join us. Hope that helps a little bit. Next question is Diane. Please remind me what type of staff deliver the programmes. So all of our staff, our team have deliberately been created and pulled together. They are our most experienced practitioner base. So a lot of our practitioners have come from NDPP programme. Some of them work across some of our other contracts in other areas of our Thrive Tribe. They are a very varied team. We have got qualified nutritionists, physical activity practitioners. Our team is supported by our clinical team. So you've met Dr. Richard Powell today, but also supported by our clinical director, dietitian, health psychologist. So there's a big team that sits behind that. But all of our staff are trained to deliver the programme in detail very effectively. We co-design, we meet with our team regularly on a monthly basis, offering clinical supervision. So yeah, we've got an incredible team here at Thrive Tribe with a lot of knowledge and experience. The team go way above and beyond what is asked of them, is what I would say. I'm frequently discussing with them the additional time they are spending with their patient groups. So I hope that reassures you a little bit. Liz, what is the dropout rate? How long is each session? And are these only face-to-face sessions? Okie dokie. So retention rate is pretty strong. Obviously, most patients are aware that there's an expectation for them to remain on the programme. Just been having a little look in the background. So our latest figures at the moment are, we are retaining, in those first 2 or 3 sessions, around about, we're only seeing around about an 8 to 12% dropout in those early sessions. And again, generally, patients that drop out tend to be for very specific reasons. So that can be changes in their personal circumstances, their overall health. It's very rare on BSOP that people just sort of disengage and we don't know what's happened to them, if that makes sense. I say we generally sort of know what's happening and why they've left. As I mentioned before, they're not only face-to-face sessions. We do work with Second Nature, who deliver the programme through a digital app. Our sessions at the moment are currently run through Microsoft Teams, but the more referrals we see and the higher the numbers are, the more we'll be able to explore face-to-face community delivery in your areas. Session numbers are currently capped at 15. Generally, on average, we see between 10 and 15 in any given group. Some of them are smaller. They have been smaller in the early days. But again, that's something we continually monitor, and we've been getting feedback from our patients on, and that seems to work quite well at the moment. Are we happy to share this? Yes, we will share the slides. Can people not on Tirzepatide self-refer? No, so there's no self-referral possible for BSOP. It has to be through a primary care referral from the prescriber. So BSOP is specifically for those patients who are being prescribed Tirzepatide for weight management. So I hope that clarifies that. Are patients allowed to continue on the medication if they are having overall well-being improved but no weight loss? I thought if after 6 months no 5% weight loss or more, then they need to come off the medication. I'm probably not the best person to answer that question. Is Richard still on the call? Do we know? Has he had to go, Jimmy?
I'm not sure, Emily, if Richard's still here, but yeah, there's a couple of questions in here. So that are probably not best aimed at Emily or the BSOP service. So the question on, around that question, are patients allowed to continue on the medication if they're having overall well-being improved but no weight loss? That's not something that we as the BSOP provider would get involved in. That's something that either your ICBs should issue guidance on, or it's your decision as a prescriber. We don't question the prescribing unless Emily says like it's immediately obvious that the person's pregnant when we receive the referral or something. So it's up to the prescriber and local guidance that's issued by your ICB. What I can say from the BSOP perspective, so as the behavioural support provider, we can continue supporting the patients even if they've disengaged with their medication. So a good example is if you're a prescriber and after the first couple of doses, have been on it for a month, they're on our BSOP program, but they say, look, I'm really struggling with these side effects. I don't think I can take the drug anymore. And they no longer take the prescription. They can continue on our BSOP program because the behavioural support could have benefits to them regardless. There's a couple of other questions that are a bit like that are not really something we can answer. There's a question from Jenny about how we define dyslipidemia.
Yeah.
That we're not. I'm not a doctor. Richard is, but he's had to disappear. So it wouldn't be us that defines that. So we probably should take that question and check in with NHS England. But as a prescriber, if you consider them to have 4 of the 5 comorbidities, they're eligible to be prescribed Tirzepatide, as long as they're also meeting the obesity threshold. And when you prescribe Tirzepatide, to follow NICE guidance, there would need to be a referral to a behavioural support program, and we are the funded provider of that in lots of areas. We offer a group program. You might have 1 in 10 people you prescribe to who you feel isn't suitable. They might have very complex needs. We need more one-to-one support than we can offer. That's fine. But we know we're very good at delivering what we're commissioned to deliver. There was one other question, which I'll just cover off, which is quite similar at the bottom, which is again from Jenny, specific guidelines on doses prescribable for the cohort, because there's specific local guidance. So again, that's not something we would necessarily involve ourselves in. The guideline on doses should be shared by your local ICB based on local pathways that they've got for diabetes, for Tirzepatide, for weight loss. It's a mixed picture. We work across 7 ICBs at the minute. They all have differing pathways. Until recently, they had differing prescribing methods and prescribing staff, etc. We know a lot of that has moved into primary care, but what I think we want to reassure everyone on the call is we have got, if you're starting to prescribe Tirzepatide and you know you need to offer behavioural support to meet NICE guidance, we have got a funded behavioural support service dedicated to that cohort of patients, which has capacity. And actually, the problem we've got is that we haven't had enough people in that service over the last year. In the first year of the programme, we received about 1/8 of the amount of referrals we were expecting, which limits the amount of group programs we can run, which limits the ability for us to offer face-to-face, for example. So the way that we can reduce waiting times, for example, if someone wants an evening course, they might have to wait 3 weeks at a minute for an evening course, because even after 3 weeks, that course might only have 6 people on it, and we'll run it with 6 people, but we know it'd be a better experience for everyone if it was busier and we could get 12 on there, or we had enough people to run them every week, for example. So yeah, I think that was the whole point of it. So there are a few questions here which are not so much things we could respond to. They're more to be directed to your ICB colleagues. I know ICBs have got a lot of challenge at the moment. There's probably a couple we can follow up with NHS England on them and share in an FAQ document, but it wouldn't be right for us to comment on some of them.
No, agreed. Thanks for that, Jimmy. Appreciate it. Just to clarify a couple of things outside of that really quickly is someone's asked if the group sessions and the app are provided together or if it's one or the other. It is one or the other. So the patient can select the pathway that is best for them. So they are offered to attend a face-to-face. At the moment, that is in digital format, online, or they can access the app digitally through Second Nature. That sometimes fits in for people, you know, around work schedules and caring commitments, etc. So they get to pick one or the other, but not coexist with each other. If they cannot use video calls or digital apps, as I say, at the moment we do not have the numbers to run BSOP specific face-to-face groups. However, we have in some circumstances used our existing NDPP service to facilitate patients face-to-face in the community. So where a patient absolutely cannot engage digitally, that is something we have done our best to accommodate through the NDPP pathway. We've got a practitioner who looks after those patients, so they now do regular check-ins with those patients to ensure that they are still receiving specific guidance around their Mounjaro prescription, but they still get the benefit of the lifestyle support through the NDPP sessions. A lot of the content is quite similar. Yes, it's not perfect, but it has worked well as an interim solution until we are in that position. Anna, I know you've asked if there's a cap for face-to-face sessions. Ideally, we'd need a minimum of 10 patients in a group to put that on face-to-face. Obviously, we have to weigh up venue hire and our practitioner time. So if we can guarantee at least 10, then we can probably look to explore a community-based intervention. I hope that helps a little bit. Okie dokie. I think some of the others fit into what you were talking about before, Jimmy. So I think I'm going to leave those there. In relation to the pilot, that was in relation to using the ERS system. I think Varsha's asked. So the pilot related to if you want to trial the ERS system within your surgeries, you need to contact NHS England for further guidance. We will circulate the email address and the details that they've provided, and you can contact them directly for support with that if that is something that you would like to explore. And I think that's it. Oh, Ellie, do patients receive scales for at home? They don't. They don't receive anything from ourselves. Patients are checking in regularly with their clinical teams, mostly monthly at the moment. So we don't provide them with scales. We do a lot of non-scalable victories with our patients. So we get them thinking about waist measurements and other sort of measurables outside of the scales as well within our sessions. So thinking about their activity levels, energy levels, and other measures of success. So it's not something that we do provide them with at the moment. I'm really conscious of time. I know a lot of you have given up your lunchtime, so thank you so much for sticking around. Obviously, you can contact me at any point. Tilly, I think my details are on the next slide, aren't they? If you do have any questions at any point, please don't hesitate to drop me an email or pick up the phone. If you've got questions, if any of you would like to come and view a session to get a feel for what it's like and you'd like to drop in and see what it's all about, please ask, do let me know. You'd be most welcome to come and sort of have a look for yourselves and see what it is we do. But like I say, we're here to support in any way that we can, so just give us a shout. But thank you all so much for your time. Really, really appreciate it. I'm glad you found it helpful. Thank you.